And welcome to the Paramedic Preceptor Orientation for the academic year 2018. This is being presented in cooperation with the Lancaster Consortium for Emergency Medicine Education, or the acronym that we've begun to use for this is the LCfEME. To make those who are unaware, the paramedic program here is a partnership between the Pennsylvania College of Health Sciences and Lancaster EMS. This consortium is known as the Lancaster Consortium for Emergency Medicine Education, and this consortium includes both the BLS and the ALS EMS certification programs. We are accredited by the CAHEP, which is the Commission on Accreditation of Allied Health Education Programs, as well as the Committee on Accreditation of Educational Programs for the Emergency Medical Services Profession, or as we refer to them as the COA-EMSP. And because of our affiliation with the Pennsylvania College of Health Sciences, we also maintain our Middle States Commission on Higher Education, as well as required by law, we are Pennsylvania DOH Bureau of EMS accredited BLS and ALS training institutions. The faculty that we have here at the consortium, the Lancaster Consortium for Emergency Medicine Education, is myself. I'm Rick Pearson, and I am the program director. There's my contact information, my Pennsylvania College of Health Sciences direct line, my work text, and cell phone, which you may utilize. But the easiest way to get a hold of me is by email. I'm usually very receptive, and I answer usually from approximately 10 a.m. to approximately 2000 hours. Below that, you'll also find the academic page here at the PA College that details our EMT and our paramedic programs. As required by Pennsylvania law as well as CAHEP accreditation, our medical director is Dr. Michael J. Rehart, who is also the EHSF Regional Medical Director, as well as he is the Lancaster EMS Service Medical Director, as well as he's an ER physician at Lancaster General. Dr. Rehart is very well in tune with the needs of current ALS and BLS practitioners, and he's very interested, and he does work with us very closely on all aspects of the educational process for EMS professionals. Other faculty that are here and dedicated to the EMS programs through the consortium are our paramedic and EMT clinical coordinator, Ernie Powell. Ernie, as a preceptor, Ernie is your first line of contact should you have an issue or need to discuss him about anything that is needed for the students in the field. There's his cell number, as well as email is usually the best way to get a hold of him. And for EMT issues directly, there's Patrick Osborne. Pat Osborne's contact information is there as well, but Pat is in charge of the EMT program, and he handles the primary academic support for in class as a primary instructor for the paramedic program, for the EMT programs. Ernie does both paramedic and EMT clinical coordination. So what is a preceptor? You're here because you have signed up and you wish to become a preceptor. Well, the definition of a preceptor is a qualified paramedic who is currently employed and or volunteers by a health care agency who agrees to collaborate with college faculty to supervise, teach, and evaluate student performances. So what are the requirements to become an ALS preceptor for the Lancaster Consortium for Emergency Medicine Education? Well, you are certified and in good standing at the paramedic level or higher. That includes a PHRN, or should you be a physician extender or something like that, you would need to follow these rules and regulations as well. You have been at the paramedic level or higher for at least 2 years practicing. You've received approval from your EMS agency manager as well as your medical director. And along with your application, you have completed and submitted the application, a resume, updated resume, as well as your most recent Con Ed record. So if you have not done that yet, please take the time to send an updated resume and your most recent Con Ed record for at least the last 2 years. Now, the reason why we do this is a CAHEP requirement. Everything that we do follows along with our accreditors. So we want to be in line with our accreditors so there's no problem when it comes down for our reaccreditation. As far as accreditation goes, the Lancaster Consortium for Emergency Medicine education, was granted a 5-year continuing accreditation by the KHEP body, and that took effect in January of 2018. So we are good at least until the next process begins, probably around 2021, 2022. The other things that you have to do, which is new for this year and comes as a follow-up due to federal regulations here at the college, is you have to have completed not only this preceptor orientation, but also all the associated required learnings that include FERPA as well as sexual harassment. And we'll get into that a little bit later, as well as if you've logged on to the Blackboard course site, you'll have access to all of that information as needed. Further, the role of your preceptor is you have the ability to supervise, teach, and evaluate students fairly and without bias. That's very important. You have to realize that these are students and they have to be taught what they don't know and taught in a well-mannered way. You should have a positive attitude toward the clinical experience and what your students are going to experience throughout the days and their shifts. Their clinical education will take them almost 11 months during their time here at the college, which their program runs August to August. You'll act as a role model as well as a mentor for the students, not only now, but also later on. You are helping us educate the future. You will work on a one-on-one basis with students. What does that mean? That means that during your shift time when you come in, the student will assist you in doing your truck checks, will assist you in all manners of checking all of the ALS and BLS equipment, as well as cleaning the rigs, basic upkeep not only of the unit, but also of the station. We are mentoring these individuals in all aspects of our profession. You should discuss and create a daily shift work plan. What are we going to do today? All of our students should be up and moving around, going on calls as needed. They cannot be cherry pickers. They have to be able to go. If you have a transport, they go on the transport, because every patient interaction can and is a learning process for them. While you may find it as routine or something like that, these individuals are looking at it as a learning process. They'll be able to see different pathologies that they've never seen before, different drug dosages, as well as they'll be able to interact with the staff and the facilities that you'll be transporting either to or from. It's very important that that is incorporated into that, as well as you'll act as a facilitator and an advocate for the student to meet their clinical objectives. It's very easy during the first few months of the educational process at the paramedic program that the students may become overwhelmed. You're to be there, hopefully, as their cheerleader. If you and your student and your preceptee have a argumentative relationship, that won't work out for either you or the student. So it's very important for you and your preceptee. You may have more than one. We'll just refer to, hopefully you'll take one at this time. But to work a shift work plan and understand and lay out those expectations early and follow through on them. Should you have any questions at any time, please feel free to either call myself or Ernie, and we'll be either more than happy to come out and do a one-on-one with the student, and you will be able to intercede, have counseling sessions. We'll be able to head this off at the pass, hopefully. As well as your role is to assist the students in making sound clinical judgment. If they're going to do something early on that is going to injure your patient, whether it's through phase 1, 2, or 3, which we'll explain later, you must intercede with that. Yes, the students are not going to know all of their drugs. Yes, their students are not going to know all of their pathologies at this point in time when you first start getting them. But the one thing about being a field instructor, a preceptor, is you will be able to follow along that student's progress. And that's the very enjoyable moment, is when that light goes on and they have that aha, I got it moment. Hopefully, you will foster an environment that will increase overall confidence in their abilities, not only in their clinical skills, but also in the manner in which they interact with you, as well as your partner, as well as the healthcare team in general. You will complete all required evaluation forms in the manner that is required. I can't overstate this enough. We are held to a very high standard when it comes to our accrediting agencies, whether they be KHEP, the COA, or the Pennsylvania Bureau of EMS, as well as the Middle States here at the Pennsylvania College. We have multiple layers, and EMS education is very different administratively and with the accreditors than any other healthcare education programs out there. We go through many different and deep layers of scrutiny that other programs do not have to do. So we have to make sure that all of our T's are crossed and our I's are dotted without reducing our standards. So please keep that in mind when we ask you to fill something out, to please be thorough. That way we can give honest, reliable, and unbiased feedback to our students. That way we can assure that they, after the end of the 12 months, they are as well prepared as they can be to become competent entry-level practitioners. And that is our mission. You can certainly read our mission statement throughout with our student handbook that's available to you through the course site. But that's what we're educating. We are educating competent entry-level practitioners. Please keep that in mind as you're evaluating your students. The other role of you as a preceptor is to comply with all the Pennsylvania College of Health Science policies, the big one being FERPA, the Family Educational Rights and Privacy Act of 1974. This is basically the HIPAA of college education. There's a standalone learning module that you must complete, but it's very important to understand that when you and your student are working together, there is a privacy, there is a personal connection that goes on between you and your student. It is unfair for you to go out and tell other people on how John or Jane Doe did that day, whether it's good or whether it's bad. That student has a right to privacy, just like every patient that we write an EPCR on has a right to privacy. That must be afforded to our students. If not, there are legal ramifications that can occur not only to the program but also to the preceptor or any of the faculty that come here and teach with us. If you go out and discuss the nature of a student's learning, their grades, their personal information, outside of that educational process between you, the teacher, the preceptor, versus the student or the preceptee. That's very important. As well as Title IX sexual harassment. There has been a very large push with Title IX. Any and or all reports of sexual harassment, from bullying on up to actual harassment, assault, will be investigated by the college, by the Title IX coordinator. And all of that is laid out in another module that you must watch and document that you have completed that in a timely manner and prior to accepting any students. So who is the student? The student is the paramedic candidate and or student that has been assigned to you, and their job is to participate in the clinical or field experience in order to fulfill the clinical requirements for the paramedic program. Now, I'm not going to bore you with the clinical requirements. The students will tell you what that is, as well as we will give you access to our skills tracking program, FSDAP, which will be explained later in this program, as well as you will have access to all of our handbooks and everything that goes along with that. As time goes on, I will continue to build that because we have just initiated for this academic year new clinical and field standards, which will be coming out later on, but is defined in written format via our student handbook, which you have access to via the course site, as well as once I get you logged into FSDAP, you'll have access to that as well. But the expectation of the student is that they understand and fulfill all the clinical requirements. They maintain open communication with the preceptor and the clinical coordinator to achieve their clinical objectives. That's very important, open lines of communication. Is professional, responsible, and respectful. And I have a few slides here in this packet that will explain to you what the effective domain is and how important that is in that idea of individuals being professional, responsible, and respectful. The student will work interdependently within a multidisciplinary system. What does that mean? They can play well with others, as well as they can play outside of their sandbox. Within EMS, we tend to think of ourselves as quite specialized, but we have to deal with not only fire departments, police departments, hospital staff, but also the general public. And we need to be able to foster that professional, responsible, and respectful attitude from the student to where despite them working on patients in a clinical manner, they also have to foster a positive affective domain, which I will explain later. And we must and we will hold our students accountable for all of their actions and decisions, good or bad. That's a good thing. When they do something good, they need praised. And when they don't do something well, they need to be remediated in such a manner to where it comes away and it's a teachable moment. Other expectations, the students must uphold the Pennsylvania College of Health Sciences policies and procedures, as well as any policies and procedures that I, as the program director, are unaware of that you must follow when you are at your place of employment, where they're actually coming to work. If they're going for a clinical shift at the local hospital, LGH has a no smoking policy. They must leave the confines of the hospital campus. Just like if you have that at your work, they cannot, they cannot smoke on duty. They cannot chew. They cannot vape. The college has those specific policies. They cannot carry weapons or something like that. They cannot record things. Utilize their phones to be recording anything. So there's a multitude of not only college but also paramedic program policies and procedures that they must follow. They must maintain a professional appearance. When they are out doing clinical and or field time, that is your job as the preceptor to make sure that that individual maintains a professional appearance. That comes down to making sure that their uniforms are stain-free, that their hair is combed, it's not all over the place. They don't have any offensive odors. They're not wearing a lot of cologne, if any cologne. They limit their rings and jewelry. They make sure that their hair is pulled up. They don't have large dangly earrings. They're wearing appropriate clothing. Their boots are polished. They're wearing a belt. Things of that nature that help us to maintain that professional appearance, as well as their ability to interact with other people. They attend all of their scheduled clinical and field hours. If you have a student that does not show up for a verified shift, we need to know about it. All of our students are required to call into the attendance line from their station or their clinical site. And that number is area code 717-947-6444. They have to call in, and then when they get there, as well as they call out. And if a student doesn't show up, they're told to be there at least 15 minutes before and expect to stay anywhere between 15 to 30 minutes after the shift to be able to get all of their work done. If they don't do that, we need to know that. There are ramifications for a no-show, no-call. In fact, those ramifications are if you have a student that does not show up for a clinical site or a field site 2 times as a no-call, no-show, they are then banned from that clinical or field site. There's no time. It's not permitted when they go to work. It will not be permitted when they're here as a student, because we are not only educating these individuals to becoming competent entry-level practitioners, we're also making them become aware of the professional regards of being an employee, whether that is a volunteer or a career status. Those are the expectations of the job and the profession. They will evaluate the practical experience as a whole, and this is where the camera gets turned on you as the preceptor. One of our requirements from KHEP is that you as the preceptor be evaluated. Now, we here at the program do not believe that evaluation occurs in a vacuum, and with that, it is not anonymous. So you and your preceptor will sit down. If something occurred, you will talk about it. If the program needs to be involved, we'll be involved. But we're looking for open signs of communications, and this is an adult learning program. They are adults. They should be able to handle communication that is not the best of information. Hey, there were some things that we found today that you didn't do as well as you should have. Let's work on this, and I'll see you next week when you come back for your next shift, and we'll work on it. As long as they're getting better and we see progress, there's not a problem. But if a student becomes stagnant and doesn't understand that, then we will intercede. But as well, on the flip side, if there is something that the student feels is not a cohesive learning environment with you, we ask that you document it so we can help you as well become a better educator. Because ultimately, even though we refer to you as a preceptor, you're ultimately an extension of the classroom here, as it's a clinical classroom. So we want to be able to be an asset for you as well, because you certainly are an asset for us. Some further expectations of the students: not only are the students required to maintain their clinical aspects, but they're also required to maintain a minimum of 80% or greater academically. So at the end of the semester, if their total academic progress is not greater than 80%, they do not progress to the next semester, and they are no longer, they're not welcome back for the second and or third semester as needed. So there are stop points and there are waypoints that we have to measure, usually every month, 2 months. As we get going here, it's a little bit less, but as we move forward into the second and third semester, that evaluation is much more frequent. And there are expectations that are met with the appropriate effective responses. And we'll talk more about the effective responses in a few moments. Effective domain. What is it? How do you measure it? It's really weird. Sometimes it's clear as mud. But the effective domain is something that our accreditors require that we measure. And it's basically how someone interacts with others. Okay, it's how someone deals with personal issues, attitudes, beliefs, behaviors, and emotions. It's one we believe, and I firmly believe it's one of the hardest things for us to influence is how someone interacts with someone else. If you have we've all worked with a medic who is, we refer to it a lot of times as a burnout syndrome. As a new student, that they should not have that, where they come in and they yell at certain types of patients because they feel it is below them as a provider to work with that type of patient. Some medics or medic students will say, I got into this field to take care of sick people, not to take care of chronic illnesses. Unfortunately, that's something that we have to teach them. We have to be able to influence these individuals. This is where professionalism comes in. We have to be able to educate and cultivate the ethics and the morals and the values of our profession, while setting aside our own beliefs and emotions. You will be on time. You will relieve your partners at least 10 minutes before the end of their shift to where they don't get a late call. You will be relieved 10 minutes early as well. The truck will be clean. It will be fueled. You will not leave something for the next person. You will treat all patients with the due respect and due regard of their position in life, not where they're at. Every person that we see demands, and this program expects everyone, and demands as well, every one of our students treat every one of the patients that they see clinically, whether it's in the field or in the hospital, with the utmost respect. And that means that every patient will get a complete assessment. They will put hands on the patient, they will listen to them, they will take a history, get their information, and take basic vital signs. There are sometimes, we understand as ALS practitioners, that sometimes they don't need ALS intervention, and that's fine, and we understand that. But each one of our patients in today's digital world sometimes can float by looking at a computer screen or not. We need every one of our students to interact face to face. They have to have touch time with those students, because those students have to have touch times with those patients. If they do not, they're not exploring the full capacity of what it is to be a professional paramedic. As educators, we must also understand that we have a responsibility to this. Okay, we have a very strong influence of our students, whether that is by grading them, by counseling them, or whatever, as well as they learn from and they model our behaviors. If you're laying on the couch when they come in at 7 a.m., they're going to model, that's okay for me. If you don't check your truck until 3 hours into your shift, that's what they're going to model. So we will propagate by not teaching them and influencing them what is the right way to do things. We ultimately will end up propagating the problem of having poor practitioners out there because they don't know, or they weren't taught properly. And that's what this program does, is we teach everyone properly. They will have plenty of time practicing out there on their own to pick up the bad habits. We do not do that. And that's something that with this education and further education that it will be providing you down the road is, how do we do that? How do we emulate that profession? We do it by walking the walk and talking the talk. That means if you're going to tell your student to have polished boots, you need to have polished boots. If you're going to tell your student or your preceptee that they need to have a pressed uniform, you should have one as well. If you're telling them to read up, you should be reading up as well. So this is a give and take. So what are the values that we want you to emulate in our students? And I put up my Johnny and Roy pictures because as a young paramedic 28, 29 years ago, I grew up in the late 70s. And Emergency 51, Rampart, Johnny and Roy, Squad 51 were my first entrances into the profession. I did not grow up in the fire department. I did not grow up in the EMS service. My father was a plumber and my mother was a cosmetologist. I found this calling, this passion that I've been doing since I was 17 years old. I found this through TV, and I've had the luck of having dinner with Randolph Mantooth through my business, and the positive influence that he had as an actor playing a fictional character on my career path. And what did they teach me? They taught me fairness. They taught me compassion, honesty, punctuality, dependability, preparedness, competence in our skills, overall professionalism, and a pride in who we are and a pride in what we do. Those are the values that I want our students to come away next August when they sit for their national registry. That's what I want them to look at. And you are the face of this program out in the clinical and field environments. So expectations, as I had said, there is a preceptor evaluation at the end of every shift. It's expected that the student complete an evaluation on the preceptor. And as you can see over here, again, they're going to ask that, were you introduced to everyone in and around the station? Did you tell them what to expect, and did you define their responsibilities for the day? Did you encourage them to ask questions? Did you assist them in their learning and professional responsibilities? Or did you just tell them to go outside and find a left-handed skyhook and don't come back until you find it? Did you help them learn and assume the responsibilities of a paramedic? You know, hey, it's not just the EMT's job just to carry the monitor. That's our job as well. So have them do as you would do. Did they correct you? Or did you correct the student in a professional manner? Did they compliment you? Did they have realistic expectations of you? If a student walks into your crew room, into your shift the first day, and within the first 3 minutes, you ask them to name 5 contraindications for isopaterenol, and they've been on the trucks a whole 5 minutes, that's an unrealistic expectation. Now, after 6-7 months of them being with you and you going over and helping them and you teaching them and learning and reevaluating their competencies in their drugs, yes, that's an expectation that should be met. But on day one, it's not. You have to be able to start at the ground up and fill any of those cracks or voids in that base education of being a competent EMT. You have to realize that some of our students come in with 1 month of EMT education. They have no actual real skills other than that they can pass a state exam. Whereas we also have students out here that have 20, 30 years as an EMT. So they may be able to advance much, much quicker. But again, there's this idea of common sense. And the only thing that is common about common sense is its uncommonality. So you have to be able to manage that in an appropriate manner. You help them to apply. They helped you to apply the knowledge to patient care. You were willing and able to discuss calls, debriefings. You showed concern for the learning rather than just, yeah, you're here, go sit down. You know, I've had cases and I've had to ask preceptors to no longer work with this program because their idea of having a preceptee was to yell at them, tell them to get in the back of the truck, sit down, shut up, and don't do anything until I tell you to. that's not a very good learning environment. There are times that, and I will admit to this, where there are times when the patient is critical and the student just does not have the faculties at this time to be able to handle that, or it's a safety issue. And then at that point, you're like, look, I understand that you want to learn, just watch for now, we'll work on this later, but for now, I have to do what I need to do. Or if it's a safety issue, the student may have to be, scolded at that point and told to go stand somewhere because they're a danger to themselves at this point. But as long as you go back and you explain it to them, that is a teachable moment. You communicated well, that you were enthusiastic for their learning and all that. That they felt that you were a good role model. That you were organized. I don't know, we had to put that word always in there, but that you're organized in some way, shape, or form. That they evaluated you fairly and not biased. We do not bias against our students. We get students from all over the tri-state area. Last year we had a student that drove from out of state 2.5 hours to our program. And they completed, and they're almost to where they wanted to be to reach their goal of being a paramedic. So when you evaluate individuals, please make sure you evaluate them fairly and without bias based on where they run or their political motivation or anything like that. Look at them as a clean sheet and evaluate them fairly. Did you interact well with patients as well as other professionals? Because again, these individuals are being mentored by you, so they will react and they will act in the way that you have taught them. Did you display a well-rounded understanding of the agency's policies as well as the protocols? Now, this is where I like to give a little soapbox moment. Is our program, we teach the national educational standards that are laid forth from us through NHTSA as well. And if you'd like to find those curriculum guidelines, you can certainly go to www.ems.gov and go and see what we have to teach. Please realize that while our students are bound by the protocols of the state of Pennsylvania, please realize that we do not teach them specific protocols. We teach them the medicine, the physiology, the anatomy, and the pathophysiology, and the general treatment styles of that pathology. We do not tell them, oh, you have to go and look at protocol number 1 to treat this patient. If we do that, we fail our students because their national registry process that they have to go through, that is a national standard. So they are taught right now, our cognitive exam through the CAT, the Computer Adaptive Test, which some of you have taken, right now has anywhere between 500 to 750,000 questions, and they're growing every year. So we cannot just say, oh, only in Pennsylvania. We have to, as educators on our end, we have to keep that wide. So there is a little bit of a hump there that you do have to get them over that educational hump. All right, as well as you would recommend this. Does the student recommend you to be to other students? Now, as I said, these do not occur in a vacuum and they are not anonymous. We will return these to you, but you should be there as they're filling them out because we have a signature spot for you. Now, the thing is, if our students do not come back with all paperwork signed by you, the preceptor, within 10 days, that student will then forfeit all of that clinical time and all of that clinical contacts to where it will no longer go towards their graduation requirements. So they have the time, they have 10 days to complete from the end of your shift that you work with them. If they cannot get that signed, now they do have the permission to email you, but as an education and FERPA requirement, you must email them on their college email, and they'll provide that to you, or Ernie can provide that to you, but you must sign these. If they don't get that, it will be deleterious to their overall progress. But this is the student evaluation form. And all of this is available up on the Blackboard course site as well as through the FISDAP account once you're able to get into that. Now, the field internship is nothing more than a specialized experience with you, the preceptor, who, again, collaborate to supervise, teach, and evaluate the students' performances. They will gain that clinical experience in order to develop their future roles as paramedic. You're going to translate that theory into practice, attain the skills necessary to become confident and competent, and develop those effective clinical decisions. So please remember, students that are entering their initial field in clinical time, okay, these are brand new students. Okay, when they come in phase 1, they are beginning their first semester of this 3-semester medic program. It goes from August to August. They will not come out to you probably until they've been in class for about a month and a half. And the only thing that we've taught them, due to we've had to wait this time to make sure all their clearances are in, all of their medical clearances are taken care of, as well as to get them into the system. Okay, these individuals will have at day 1, when they come out to you, we will have gone over an ALS assessment, a physical assessment, head to toe, checking everything. Okay, that is what they will have, and they will continue to build up on that. These individuals, by the time they come out to you, KHEP requires that they demonstrate entry-level competencies at the EMT basic level. So they should know how to apply O2, how to ventilate a patient, how to provide basic airway manipulation, how to do vital signs, and how to start working their way up and through basic scene safety management, stuff like that. That is what the basic level competencies of an EMT basic are. But please, please, please remember that these are students and cannot and will not be expected to know everything. If you're the type of preceptor that comes in, and as I said, day 1, 3 minutes after the start of their first shift, they have to be able to recite rhyme and reason to the triple K 1822 alphas on why that ambulance sitting out there is a type 2 and what the voltage requirements are on the inverter. That's not appropriate. That's not appropriate to ask them, give me, the in-depth mechanism of action, as I said earlier, is of isoprel. 8 months later, after we've gone over it and you've educated them as what their expectations are, then yes, those are all fair questions. But until that time, please remember that these are students and they are in class and they are in this process to learn. Now, this clinical experience is divided into 3 phases. Phase 1, which we refer to as an intermediate phase. Phase 2, which is the advanced phase, and Team 3, which is your team leader phase. And we'll explain each one of those as we go along. But in Phase 1, we want to make sure that the following competencies are met. That the individual has opportune time to perform advanced assessments on every patient. Whether you believe that it should just be a refusal, that candidate should be out there doing every assessment, that they start to develop there and begin to function as a team leader for ALS BLS calls. But again, that's a long range objective and competency that we want them to see, but they got to start working and have that idea in the back of their head. They're able to develop a detailed treatment plan, as well as one big thing is documentation, that they're able to complete an accurate and FISDAP or EPCR report, whichever you want to discuss that as. But they have to write and document a narrative type formatted PCR. I, in the program, cannot teach every different EPCR program out there, whether you're using EMS charts, ESO, the Amazon, the Firehouse, or whatever is that you use at your surface. We will teach them how to write a good narrative, how to paint a picture using words, and that's very important to know that. Also, please note that these Phase 1 students are permitted to perform some advanced skills under the direct supervision of the preceptor. Okay, they may only perform these skills that they have been approved of and signed off on their skills verification form. It's very important that we understand and that you understand that there are legal ramifications within the scope of practice. If a paramedic student functions outside of their scope of practice that is in direct violation with the Pennsylvania rules and regulations, I must report that to our medical director, and then a full and complete investigation will occur, up to and including sending that to the regional council as well as to the State Department for potential further investigation and discipline. Should that come back, the individual that has been exposed to that, the student as well as the preceptor, will be counseled, but the student may run the risk of being expelled from the program for doing things outside of their scope of practice, have they not been cleared on that. So for you as the evaluator, the preceptor, if the student does not have their skills verification, you cannot verify what they're able to do. So I ask you, please make sure that the student has that every day. If they do not have it, they may not do any advanced skills. So make sure that every shift that you see that skills report on what the student is allowed and not allowed to do. Students will complain that, oh, I may only get a chance to do one needle decompression. I'm sorry. I've had students that said, well, I saw something as in my job and one of the preceptors was going to allow me to do it. No, it's the second day of school. You haven't had the theory as well as you haven't been taught the skill. Therefore, you're not permitted to do it. We walk a fine line within the Bureau of EMS and state regulations of scope of practice as teaching basic students advanced skills. And that's very important that we have to follow. So please be mindful of that. This is a cover form that we'll share with you, but basically the student has to fill this out. You do not require a signature, but your name goes on it in the clinical site at the time. This is a form that allows Ernie to see what the student did, not only time-wise, but also skills-wise and patient-wise during that shift. And this will be put on top of the individual forms that you are responsible for signing. Here is the form that you need to do. It's broken down. This is the phase 1 eval form. Okay, it's a multiple page that documents multiple ideas. Okay, it provides a rating of 1 to 3 and non-applicable. 1 is the excellent and 3 being unacceptable. When we look at 1, 2, and 3, this is sort of like golf. The lower the number, the better the idea. So please be mindful as you X things out. The lower the number, the better. Now, just a little bit of clarification. Non-applicable. Anything that's marked non-applicable needs to have documentation attached to it. As it says here, NA should only be used when NA is truly appropriate. For example, if you mark non-applicable for scene size up, I need documentation on why you feel that was non-applicable, because a paramedic candidate has been taught in their EMT basic that they're able to do a basic scene size up. And that should be, and it being in their current scope, identify what's what's access, what's egress, little things like that. But as you go along, the ability to discuss those expected outcomes of any treatment that they provided may be beyond their scope right now, but certainly can be picked up in phase 2 or phase 3. So we're asking you for complete documentation. If it's not, if it's not applicable, okay, we could in early on. But as we go along, if you just mark NA, we need to have documentation, and Ernie will return any NA remarks for documentation. And for that student, please realize that if we return anything, that 10-day time frame still applies. So please be mindful of that as we move along with that. Now, on the last page, we have updated this from last year. The last page has been adjusted for any additional information. One thing that we have found doing our accreditation background work is preceptors will mark NA. And they'll fail to tell us why something is going on. And then we'll hear about it through the grapevine that so-and-so didn't do well, and it comes down to that FERPA issue. You're discussing, a preceptor cannot go out and discuss with other people a student's progress without that student's explicit consent. But you certainly can call myself, you can call Ernie, or if you see Dr. Rehart, we can discuss that way. But if you want us to call you because there's something sensitive that you don't want to put down or something of that nature, tell us what's going on. We will accept emails. We will have one-on-one conversations with anybody in relation to our students. So we want this to be a two-way street when it comes to communication. So at the bottom of those pages, student has to sign it. You have to sign it. The time that you signed the paperwork, the number of patients for the shift. And if you want to consult with any of us, please give us a number or an email, and we'll give you a call as soon as we get that paperwork back. All right? Or you have our contact information. Call us or text us regarding that. When we get into further on into phase 1, students have to run a minimum of 25 ALS calls. Now that is decreased from previous years. Previously it used to be 33, 33, and 33 across the board, but we found out that students struggled with that 33 in the first semester because they don't actually get out into the field and get meaningful calls, at least until halfway, which is 2 months through a 4-month semester. So we were setting them up for failure with that. Now there are some programmatic stuff that we can do on this back end, but so what we wanted to do is we made them go into the ER a lot more this semester, and they only have to do 25 ALS calls, and about that's 2.5 months. And if you work with a busy service, that's very easily achievable. The students have to run with a minimum of at least 2 different preceptors. One rule that we have that you will read for FERPA in the Title IX, if you are involved in any type of relationship outside of the classroom with a student, we ask that you do not evaluate that student as a preceptor. That also do not enter into any relationships with the students, usually romantic in that case. That is a clear and direct violation of the Pennsylvania College of Health Sciences rules and regulations. Even though you are a preceptor and outside the school and legally your clinical precepting is viewed as an extension of our classroom, and that's one of the big no-nos in academia. If the program finds out that you are in a relationship, whether it's husband and wife, boyfriend, girlfriend, or some other significant other, or even just dating, and you are precepting a student of ours, any evaluations that are received prior to that point will become null and void, to where they will lose the student will lose the time as well as the clinical shifts. Because if you are entered into those types of relationships with a student, it's in violation of college policy, as well as we cannot guarantee that you are being unbiased in your assessment of the student. So that's why we see that we require at least 2 different preceptors. You have to score at least 2s in all pertinent categories. Anything that is documented less than a 2 or satisfactory must be thoroughly documented, because again, you can just pencil whip someone, but how is the student supposed to get better if they don't know? As well as, how do we know that on the back end? You and I don't, discuss, regularly. We'd love to be able to do that, and we're going to make some venues to be able to do that. But right now, the written communication is the best way for us to follow that. As well as at the end of the phases, the student will be required to obtain the signature of at least 1 preceptor in addition to the primary preceptor that is documenting a readiness to move into phase 2. Now, when this comes back, you'll get this form the students will ask you. Okay, the signature on these forms just indicate that you, whoever is signing, and the primary preceptor are comfortable with the student and is prepared for the next phase. Now, here comes the questions invariably. Well, what if the preceptor doesn't believe that that individual should not advance, which is their right? We need to have it clearly documented. Just because you say they're not ready to progress, I need, and the program needs, solid documentation on why that has not occurred. And that just cannot occur based on 1 evaluation. That's why we have more than 1 evaluation at more than 1 time. So please realize, if you don't want to sign for someone, that is your prerogative. But if you come back and say, well, that student never should have passed, but on our end, we have no documentation as such, and it's just subjective and not objective evaluation of that student, we can't stand on that. That's a very weak 2-legged stool. We need 3 legs to be able to stand on to make that, because the student has a right to be evaluated fairly, and that's the only way, is with clear lines of communication is that student able to do that. Did we assess that student in that area? Did we provide remediation? These are students, and again, they're not expected to know everything first day. Should you have any questions or you wish to discuss that idea with me, please feel free to give me a call. In phase 2, basically what happens, the student has gone on through a lot more theory. It has a lot more specialty clinics with that. And we've graduated from the first 25 ALS calls to now we're in second semester. They have to achieve 41 ALS calls. Okay, at this point, they should function as a quote team leader, but you're still there as the preceptor to give them fallback, to help them along. At this point, early on in phase 2, there should be minimal guidance. You would hope so, but there are students that will progress at different times. So there's no eureka point yet. They should be able to develop a detailed treatment plan that involves treatment, transport, and all associated treatments on the way to the hospital, as well as giving reports. And everything that we have fostered in that first semester is just extrapolated on, and we give them more time to function in the role as a candidate or a student paramedic, but still having that fallback of having a seasoned vet behind them to help them through things that they have never seen. At this point, they should be well versed in Pennsylvania BLS and ALS protocols as they go along. Again, we don't teach them the protocols there, but they have to function within that system. And they have their documentation must become better. Things that they go along. That is something that we are going to, and we evaluate here. We, myself and Ernie, evaluate at least 2 PCRs a semester, 4-point value. We will put that rubric that we use for evaluation up there. So when you ask the student, let me read your PCR, they have to be able to read it, and you grade them as well. And you send that along with that, and we'll certainly read that, and we will provide midstream corrections as well. Here again, it's the idea that there may be things that come up. It's beginning of trauma season in phase 2. You see a patient with multi-system trauma. They have a pneumothorax, and definitive treatment for that would be a needle decompression. But the student has not been signed off on it. They are not permitted to do it. It's outside of their scope of practice at that point, and we have not cleared them for that. So please be mindful, again, checking that at the beginning of every shift. What are you allowed? What are the expectations? If this does come up, here's how we're going to handle it. I will do it as the senior preceptor. You will watch, you will assist me, and you will learn from it. It will be a teachable moment, but you can actually do the skill. And our FISDEP reporting will allow students to observe skills and still receive credit for it. On the advanced form, they have to have minimum 41 calls. At least 50% of all the shifts that they are with in the field are with their primary preceptor. They should score 2s or better in all pertinent categories. Anything that is less than satisfactory or a 2 must be documented thoroughly. They have to obtain the signature of the primary preceptor at the end of the semester. And then now, instead of just one other preceptor, this is where we get at least 3 preceptors. Research has shown that you should have at least 3 independent validations of what is going on, because each preceptor has different skill set, has different observational skills, what is important, what is not. So we don't want someone to become a mini-me of one certain preceptor. We want them to be evaluated fairly across a minimum of 3. You can certainly have 4, but once we start getting into 4, it becomes very difficult to follow trends, as well as to have the student remember who they precepted with as we go along. As well as it becomes important for us down the road with some other projects we'll be working on with you as the preceptor going down. And here's phase 2 advancement form. It's pretty much the same thing as phase 1. It's just it has that secondary and tertiary signature on that. And again, with this, documentation is key. If you feel that the student should not move from phase 2 into phase 3, we need to know why. We need to have hard, fast documentation. The question always comes up, well, how deep do you want me to go? Be as deep as you want. You want to call us? Give us a call. The old adage is when one is providing feedback, if someone says, you suck, okay, thank you, I appreciate that, but how do I suck? What did I do that in your observation was not up to par, to satisfactory? It becomes problematic when we have preceptors say, well, that individual shouldn't be a paramedic. Okay, document it. Tell me why. You have to go on record. If you're not comfortable doing that, then you may want to reevaluate why you want to become a preceptor. We need your ability to objectively evaluate our students. Now, team 3, team leaders, which is in semester 3. The purpose of the team leader phase is to basically watch these. This is almost 9 months into the program. We want to see our students become, at this point, competent entry-level practitioners. They will have had 66 calls, ALS and or BLS, to where these individuals are now practicing as best they can within their scope of practice as a competent entry-level paramedic. Now, you're still there to provide guidance, but basically they should be leading the call. They should be saying, hey, I need this, 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 and this. You, being an observer and still having the ability to walk in and say, okay, I need to do this, or this is an unsafe situation, we go in and provide that feedback with that. And by there's still some students that may struggle with a couple things. It may be a very comprehensive medical case or a multi-organ system issue that they're flustered in. There's multiple patients at MCI or something like that. But again, they should be able to function on your everyday call as a team leader with no help and or minimal assistance intervention from the preceptor. This is a very gray area sometimes, he forgot, or the student forgot to put the pulse ox on. Okay, why did they forgot? Well, they had capnography on. Okay, was that something that they just overlooked? Does that disqualify them as a team lead? No, because we all forget things. You're there to help them along and foster a positive reinforcement. The student should show competent skills during this phase and should be able to function as a competent entry-level medic. At this phase, we've taken away the NA, the 1 and 2s, and 3s. At this phase, we basically evaluate them as you believe, are they competent or not competent? If they are not competent, we need documentation as why you feel they are not competent. If it's something that they didn't do or it was not applicable, document it. But if it's something that you feel that they are not competent, we will not accept that form without a detailed documentation onto why that student was deemed not competent in that call. And again, the preceptor should be providing the student minimal to no assistance in this phase. Okay, and again, on this form, there is only 2 choices, competent and not competent. When you complete the form, when it's non-competent, indicate it with the overall documentation. And finally, here we can see that the phase 3 completion form, the signature on these forms simply indicate that by signing the form, the preceptor state that the student has demonstrated safe and entry-level competent behavior based on the performance objectives outlined on the form. Okay, with that they've run a minimum of 33 team leads, at least 50% are with the primary preceptor, if possible. And during this time, 3rd semester, we understand that vacations occur, shift work, and everything else like that. Obtain a signature and be competent in at least 25 consecutive team leader calls. We do build in a little bit of leeway. Oh, you didn't have a good day, something like that. So we will work on that. But again, this is very important. If you're not going to sign this and you're going to say that the student is not competent to sit for their national registry and or graduate from this program, we need solid documentation. Solid. We just can't take hearsay, and we won't take hearsay in that. So there are standards that are being set, and those standards will be followed not only by the candidates, but also by you, the preceptors. And again, we've talked about this, but just to reiterate, the preceptor must complete and sign all of the clinical evaluation forms for the student to receive credit for the shift. That's not only their hours, but also their actual clinical interactions. If not signed by the student will have 10 days to complete from the end of the shift to get that signed. They can email you, they can scan it into you, get it back to them. But again, if they don't get your signature within 10 days, the shift and all the contacts will be deleted. Student will also complete the cover sheet. By the end of 1st semester, they will be pros at submitting all of this paperwork. And that's half of the learning process during this 1st semester, is learning how to operate in FISDAP and making sure all of the paperwork is done. All the T's are crossed and all the I's are dotted. Because that is a requirement of the profession, that all of your PCR is done in a clear and efficient manner, because if they're not, the state requires 72 hours. So there are, there are standards for that which we have to do. Here you can see the evaluation sheet. This is just a repeat of what we've done previously. But the new sheet that we will see here is the team leader phase. This is important. Where is the integrity? Is there empathy? Is there self-motivation? Okay, appearance, personal behaviors, self-confidence, communications, times management, and teamwork and diplomacy. Okay, they are either competent or not competent, or NA. If they are not competent or it wasn't observed, we need, as a program, need documentation. And again, we'll see the evaluation of the preceptor as well. So as you go through here, assigning a score, when we see somebody that gets a 1, they consistently exceed the standard. If it's 2, they meet the standard. If it's a 3, it's unacceptable early on in phase 1 and 2. If it's an NA, they didn't observe it. Okay, so what do we do? How do we denote that? Well, the rubric that we utilize for appearance and attendance, if you feel that they arrived early for shift, that's documented, that's easy to measure, that their uniform was neat, clean, tailored, and shoes shined without stains, they're wearing a belt, they don't have excessive perfume on, all that other stuff. Overall professional appearance, they have pens, they brought their books with them. If you're going to be on the road all day, they brought a lunch or they have money, stuff like that. You give them an excellent. If they arrived on time and their uniform is neat, pressed, clean, fits, and is worn properly, but there's just something off, document them as average. But again, document it. Tell them why they didn't meet your idea of what excellence is. And what is unacceptable? If they arrived late. Now, I'm a Boy Scout. On time is 15 minutes early. On time is late, and late is unacceptable. So I expect my students to be ready and raring to go 10 to 15 minutes before the beginning of their shift. Because again, that's something that as a standard we want to promote within our profession. If they are 30 seconds late, they are late. Okay, if they are on time, if they walk in the door at 7 o'clock, and they got their book bag on, they got their shirt over their arm, their boots aren't tied, or something like that, that's unacceptable. They have arrived late. If they look like they just crawled out of bed and they pulled their shirt out of their book bag and it's been sitting underneath a bag of leaking Coke, that's unprofessional. That is unacceptable. If they smell like they slept in their gear, that's unacceptable. We need to be able to mold these individuals into the professionals that are going to be replacing us in several years, hopefully. All right. Communication skills, very important. Do they consistently communicate professionally and within a proper, effective domain? Crews, patients, family, and facility staff without prompting and they're in a proper, effective manner. Do they give a good report? That's something that we're always working on, is getting a good report. Are they average or are they unacceptable? If all they do is walk around grumpy and that's unacceptable. If they give an incomplete report, why was it incomplete? Just because they didn't give a complete report because the patient was unconscious and they couldn't find out their sample history, well, that's not unacceptable. They've done the best that they can, and that's where you're able to apply your objective evaluation to that. Do they have a readiness to learn? Are they ready to learn? I'm not going to bore you with reading this, but are they ready to learn? Do they take your feedback well? Feedback is a gift. That's the way that we learn how to do this stuff. Do they come in teamwork? Do they come in and they help you clean? Do they walk in, drop their bags, go, oh man, I had a rough night. All right, and they pass out on the couch. Unacceptable. Send them home. And I haven't stated this yet. Ultimately, you're in charge of that student. If that student walks in and they are unbearable, or if they don't want to do what is required of them, send them home. File an email, send an email to Ernie and myself, said, hey, John or Jane Doe came into class. They came into the clinical experience. They were unprepared. They came in, they sat down, they complained about everything. They didn't help with station chores. They didn't help cleaning up the truck. They didn't help with, checking the truck. And they were overall just in a bad mood. That's not an education process that you as the preceptor should be experiencing. They shouldn't be doing that, as well as your patients should not be experiencing that. Send them home. But just let us know why. Document it. because that is an effective domain issue that I and Ernie have to, and possibly Dr. Rehart will get involved, and we will take care of it. Teamwork. Did they go out and help you as needed? Scene size up survey. Again, when they get out of the trucks and on any federally funded road, they should be wearing their OSHA jackets. They should be wearing their OSHA gear. Are they using proper PPE? Are they wearing gloves? Every one of my students, every student from the EMT to the paramedic level, or if they are within arm's reach of a patient, they must be wearing safety glasses. If they wear regular glasses, I will provide them with side shields, but every student of mine will be wearing safety glasses. If Ernie and I go out and about and do observations and ride-alongs, if we see a student, even in passing, the standard, and they will be quite aware, if we see them without their glasses on, whether that is a clinical ER shift, respiratory, or on the truck, they will be excused for that day, and their time and their clinical experiences will not be recorded. So it's very important that you tell the students, that's in the handbook, I did not put it in this presentation, but every student must wear their safety eyewear, even if the patient is not coughing or anything else like that. They have to be prepared for the unexpected. So arm's reach of any patient from cradle to the grave will be wearing safety glasses and safety facial apparel. With that, did they do an initial assessment? Did they do a detailed assessment with everything that goes along with that? Please find that and document that appropriately. And they're told from the beginning, day one, every patient demands, I demand that patient get a full assessment, primary and secondary. Vitals, they don't have to do a monitor on every patient, but they will get vitals. They will talk to that patient, and they will take a blood pressure. They will take a pulse. They will take a pulse ox. Okay, they will do that on every patient that they come in contact with as it goes along. When you evaluate them, is their treatment appropriate? If you end up having a patient that is suffering from a burn, second or third degree burn, but the first thing they reach for is the Narcan, that's not a good treatment decision. That's unacceptable. But talk to them about it. Find out why. Find out where they were going. Redirect them appropriately. And again, please realize that as they walk in, day one, they're students. Up until the day they leave, they're students. But our expectations grow with them. Think of it as a pyramid. We lay the base in semester 1 and semester 2, and by semester 3, they're chomping at the bit, ready to go with that if we've done our jobs properly. Reassessment, same thing. After every medication, after every patient change, taking vitals, looking at trends, talking about everything that goes along, any drugs that you might do. We've already talked about documentation in the course guide, course site, as well as FSDAP. I will provide you with a rubric for documentation scoring. So FSDAP, I've talked about it a few times. What is it? How do you use it? Well, FSDAP began as a grant-funded research project that was known as the Field Internship Student Data Acquisition Project, FISDAP. Well, after they completed that research project, they actually turned it into the FSDAP that we know now, which is basically a large database where we log, the students log information regarding their field and clinical experiences, what patients they've seen, what skills they did, what schedule they're on, everything else like that. And it'll be there. I'll gladly come to your service if you want to run down on it. But once I give you access, you'll be able to go in and see everything. When it comes time for the program to present reports and documentation to CAHAP, it allows us to hit a database generated form, and everything comes out for us. Every year we have to report back to CAHAP. In fact, I just submitted our end of program report on 9/1 on how the students did last year, and we have to account. It's penny pinching. It is literally, we have to account for every IV, every intubation, every ventilation, every skill that our students do. We have to document it, and they are meeting the minimum requirements of our program. If you want to know what the minimum requirements are, that is also up there on the course site, as well as in FSDAP, as well as in the student handbook, which you can find not only on FSDAP, but also on our course site. I will assign you a FSDAP logon. It'll be sent to your email that you provided me, that you got the email to come in and log into course site. Along with the Blackboard site, you'll find everything you need in the resource center within FSDAP. And then once you're in FSDAP, as you go along, you will have access to review the students' PCRs. Please note, just as a reminder, that your students may not write your services PCRs. That is a legal issue. If that were to occur, the program is now held liable for your services PCRs. We do it through FSDAP, and FSDAP is a HIPAA compliant process where they give ages and genders, but they do not give names or any other type of identifying markers that would further identify the student, the patient that you're taking care of. Students usually will complete the narrative in a word processor and then further cut and paste it into FSDAP. So you can see the PCR in many different ways. So just some precepting pearls that I have here for you. You are working with the students. They need taught. You can't assume that the student knows it. Again, common sense. The only thing that's common about common sense is its uncommonality. I have students that are 1 month out of EMT school to 20 years to 30 years out of EMT school. And each one of those in between is a continuum. And each person has a different need. Strengths and weaknesses. Some have more strengths, some have more weaknesses. So we have to be able and work together as a team. Please remember, be a mentor. Don't dictate to these people. They're adult learners. These individuals, just like you did, more than likely, more than 2 years ago, are struggling. They're struggling in holding down a full-time job while coming to school in a full-time program. Even though they only come to class 2 days a week with occasional weekends, these individuals have families. Okay, they're either in the clinical, they're in class, or they're out on a truck. So they're tired, they're struggling. They need you to help them. So mentor them. Don't dictate to them. Be kind. Okay, you can be kind. A kind word, hey, you know what, go ahead and I'll buy you an ice cream, but be kind to them. Understand that, there is a lot of information that is being dumped on them very quickly, and they have to be able to remember it with a certain competency very, very quickly. So please be kind. Remember the struggle of you being a paramedic student. I remember mine. It was 28 years ago in the basement of the Visual Arts Center on the north side. I was in what was known as a fast track program at the time. It was 6 months. We were in class 3 nights a week, and we were in clinical on Saturdays and Sundays. So we would go to school Monday, Wednesday, Thursdays, and Saturday and Sunday we did 8 to 16 hours a day of clinical time. And the struggle was real. And during that time, I also worked as an EMT. So please remember that. Be honest in your assessments, but don't be cruel. Just remember the struggle. Be kind. Give them honest, objective feedback. Document honestly. Just like I said, be honest in your assessments and honestly, because that's the only way these students are going to get any better. And if it comes down, you don't feel somebody's competent, document it. Because if not, I'm going to come back. The program will come back, and we will walk back through every form that student was evaluated on, and we're going to look, and we're going to say with Dr. Rehart, hey, Dr. Rehart, what do you think about this? And if we can't find a progression, oh, great. Ooh, not competent. Well, wait a minute. Now you're saying not competent after one bad experience? That doesn't jive. Now, if there's something that I've seen 3, 4, 5 times, yeah, that's a trend. We intercede on that. But if there's only one, that's an outlier. I need to be able to document it. Okay, I will gladly come and work with anyone that has any questions regarding this. Remember that any questions, please remember that Ernie and I have an open door policy. Email, cell phone, text, just let us know who you are, who the student is, and what the issues are. Document them. The student needs to be aware of it. I'm not going to hide anything from either you, the preceptor, or the student when it comes to the educational process. This is a team event because your time with our student lays the foundation for their career, so they can be seen as a mirror looking back at you. So please remember that. If you have a problem with certain things within your skill set, the student's going to emulate that, and they're going to show you exactly what you taught them, either through action and or inaction. It's sort of like having that humbling moment as having your children, when you don't know if that moment of sarcasm is just trying to get back at you or if it's brilliance because you educated them that way. So what's next? Well, the next thing that you want to do is take the quiz that is related to this learning module. And it's not a hard quiz. I think you can do it. Review and take the quizzes that are related to the FERPA and the Title IX modules. Those are very, very, very important. And what you'll see is every year at the beginning of the new academic year, each one of you will have to redo these. It's not because I don't think you learned it the first time. It's just that under federal law and based on all of our accreditors, we must do that. So please don't become angry in a year. I just did that. No, you did it a year ago and some stuff has changed, because as we go forward, our accreditation makes us do certain things that we may or may not agree with, but we have to follow through with it to maintain our KHEP accreditation. Once we get you the FSDAP information, you'll receive your logon. The FSDAP information is going to take a little bit longer because I have to input everybody's name and profile into that individually. And I have over 300 preceptors right now. So that will take some time. Any questions? Again, we have an open door policy. Contact myself or Ernie. Questions, concerns, or clarifications. First thing I would say, go and look at our student handbook. We usually have... there's usually a part in that it is indexed properly, and that's a work in progress. Every year we go back and I have to redo that. When I first started as a program director about 8 years ago, my student handbook was about 19 pages long. The version that you're reading this year is over 90. So as well as there's multiple ones you have to be aware of, the handbooks and all of the policies and procedures with that. Watch your emails for updated information as the semester progresses. We will be extending some educational moments for you. We will have on-site education should you want to come here to the PA College. We have opportunities if you would like to come in and be a subject matter expert and help us with labs. We'll certainly do that, as well as there will be some educational opportunities for you at a discounted rate through the consortium and Lancaster EMS based on some criteria which we'll be getting out to you in the next coming months as we clarify those. So that's something is new as well. One of those will be Con Ed for your precepting time, as well as discounted ACLS, PAL, CPR, and ITLS classes. We'll be working those as, and the criteria for those will be coming out momentarily. So again, just so in case you need it again, contact information. You could reach me at any one of those numbers. Again, email works best for me, as well as there's Ernie's contact information should you have any questions, comments, or concerns. And at this point, I'd like to thank you for taking your time and doing all of this. I know it means a lot for me and Ernie and Dr. Rehart that you do this and you take on, we pass this on from one generation to the next. And really with the profession that we have and the skills that you impart and the professionalism that you impart in our students is not overlooked. So again, thank you from the program. Thank you from the Lancaster Consortium for Emergency Medicine Education. Thank you from the Pennsylvania College. Thank you from Lancaster EMS. And more important, and most importantly, thank you for me for doing this. And if I can be personally of any assistance to you, to your staff, to your service in any way, shape, or form, please let me know. Until we meet again, or until the next voiceover PowerPoint, thank you and have a good night.